I would like to request Dr. Abdullah Shahriar to present his paper on innovative percutaneous perimembranous VSD closure by ADO1 device.
Thank you, Rizwana. And also, I'm feeling very glad and delighted that IPDI authority has given me that opportunity to deliver such a presentation. Good morning, dear honorable teachers, my chairperson, and my colleagues. Assalamu alaikum. I'm going to present this innovative VSD device closer with ADO1 duct occluder. I'm Abdullah Shahriar. I'm the department head of National Institute of Cardiovascular Disease. So the patient that we're dealing with for this device closer, she was a 4-year-old lovely girl, admitted to the hospital with complaints of frequent chest infections and palpitation. On examination, she has got temperature normal, dental hygiene is good, pulse 92 per minute, blood pressure is 82/39 millimeter mercury. There's no edema, lungs, no findings. On cardiovascular examination, the apex is shifted, JVP not raised, pansystolic murmur, left lower sternal grade 3/6. P2 is not palpable. So here is about the investigations we have gone through for the diagnosis and also for the management of the patients. There's X-ray, you have seen the chest X-ray, it's dilated, there is ventricular hypertrophy, and ECG findings also show the V6, there is a, in V1 is a S-wave, deep S-wave, and the R-wave in V6. So echo shows I have encrypted my clips, so I have shown this still picture of echo. Echo shows 6.6 millimeter moderate size PM VSD with muscle extension, PPG of 79 millimeter mercury, left to right shunt, LLB mildly dilated, at TR grade 1, no air, no MR, LV was 49 millimeter mercury, QPS was 1.8:1, and you have seen that the lesion is more or less cylindrical, slight tapering in the RV end. So diagnosis of moderate PMVSD with left to right shunt with a mild hypertension. So we counseled the parents and patient was prepared for VSD device closure. Anesthetic pre-checkup duly done. We started injection ceftriaxone 100 mg per kg day. So inclusion criteria that we are taking account that the things, because whenever we are thinking about this size of VSD, there is no available usable device because we have only device that is ADO2, but the highest size of the ADO2 is 6. So we are in a very difficult position. So we don't have any symmetrical device like Shanghai metal device. We don't have multifunctional device. So the only option is there is the ADO1. So, but whenever thinking of ADO1, we have to think about the inclusion criteria as what is the distance of the aortic rim, any infringement of the tricuspid valve, and also the dual end, or the RV and LV end is also your consideration. Other than this, we also consider the clinical status of the patient, whether the patient is subtle or not. Finally, we, after calculating all these things, we started the device closer. So we preferred, we have no option, we have to go for an antegrade access for AD1 occluder, punctured both femoral vein and artery. The hardware we gone through 5 French femoral sheath, 2 sets, hydrophilic 0.225 angle tip guide, 2 thermo wire, 4 French right Judkins diagnostic catheter, 5 French end hole multi-purpose catheter, 4 French pigtail with guide wire, 10 millimeter Amplas gooseneck snare, 28-inch Amplas exchange wire, 2 centimeter. Also, we are prepared with noodles wire if when it's needed. So now first we have go for angiogram. In the angiogram, it was a 30-degree oblique and cranial view to see the maximum oblique operation of the VSD size. Now, when we have measured the VSD, we have along with the multi-purpose. And the wire, thermo wire, we have proceeded along the VSD, and now you have seen the wire is inside the superior vena cava, RB to superior vena cava. Now, along with the wire guidance, we are pushing the catheter inside the RV from LV to RV end. Now, the snare being forwarded through the femoral venous approach and to interrupt the wire, which was inside the superior vena cava. Now, the snare has captured the wire, and our objective was to make a loop so that we can have a track from LV to RV. Snare is turning down the wire through the femoral vein to have the loop. So there's a loop. Now the device is being, the ADO1 device has been forwarded through that loop in the RV side. Now it is in RV side. Now the LV end had been opened in the LV side. This is the full shape of the device, AD2. It's released, AD1 device. Now dye has been given. And this is the echo post device closure status, the plex view, different view. So we go for follow-up, periodic clinical follow-up, long-term fever, no chest pain, no good rentalazine, antibiotic ceftriaxone is continued. Vorexon is given for 12 or 3 days. ECG was done so that any sign of heart block. Echocardiograph was done periodically. So take-home message is AD1 ocular can be used for moderate size PMVSD closure, into surgical closure. Device is cheaper and safer also if handled with skill guidance. Accurate profiling of VSD, TFVSL position is essential for the safe of landing of the device. Antegrade procedure, though lengthy, but could be a better profile in context of aortic valve position. Optimum size should be the concern, and long-term observation needed regarding congenital drugs. So this is the day, happiest day. We all remembered our father of the nation. Thank you very much.